Hello, welcome back. This is podcast number 3 in the nursing process series that I'm putting together. We're going to be talking about the nursing diagnosis. So we've done 2 already, and the first one was just an overview where we looked at critical thinking. The second one, we dove into the assessment side of things, and today we're going to be again talking about diagnosis. So again, really to kind of give you a reference as far as to where we are. Remember our mnemonic ADDPIVE, standing for Assessment, Diagnosis, Plan, Implementation, and Evaluation. We just did one on assessment, so now we're focusing on the diagnosis, the second part in the nursing process. So today what we're going to really be talking about is, I like this nursing diagnosis setting the stage, because the diagnosis, that's what we really are. So this is going to set us up for our plan. This is going to really tell us the direction that we're heading for. This is after we look at our data, we gather our data through our assessment, and now we have all this information here that we need to sort through. We talked a little bit about cues, about clustering, identifying things in the assessment portion. Now is where we're really going to apply that critical thinking and develop our nursing diagnosis. So before we really get in, again, we kind of talked about this in lecture in class with our assessment day, but I wanted to go over this again because this is an important point to really remind ourselves and to look at why are we spending all this time, all this energy on nursing diagnosis, the nursing process. And the argument and the comment that I hear most frequently, this is all done by the RN, so why do we have to worry about it at the LPN level? Yes, it is done by the RN. That's kind of the meat and potatoes of the RN, especially in the acute care side. However, and this is a big however, I'm not using a but here, we don't need big buts, but however, it's also an expectation that the LPN knows how to do this. So we're talking about long-term care admissions, family practices. You may be involved with this, especially if you have a small family practice and you may be the only other licensed professional outside of the physician, or if your RN is just stuck on phone triage. You're the one there in the patient room. You are the one gathering this data. You're the one who's actually interacting with this patient. So you are the best person to develop a nursing care plan. Even if you are in the acute care setting and the RN is putting together this care plan for your patient, you may still have to write something up, develop something that the RN is going to sign off onto, but also, probably even more importantly, this care plan is being executed by the entire treatment team, of which you are a part of. So you need to know what the nursing process is. You need to know the components of the nursing care plan at or above the same level as the RN, as the physician, as everybody else, because the expectation that you know what the care plan is, you know what the point of it is, you know how it's constructed, and you know how to work within it and work with it. And also, of course, is the expectation of this course for you to be able to develop care plans for your patients that you're assigned to. So if you're going to do something, you need to be able to do it well. You need to be able to do it proficiently and effectively. So that's also why we're spending an awful lot of time on this as well. So the next part here, to start us off, so where exactly does the nursing diagnosis fall? So we have this ADDPIVE mnemonic. We're set between the assessment and the plan and implementation and all of that stuff. But really, to truly understand how the nursing diagnosis works, is I really like this graphic. And again, all this stuff comes out of the Wilkinson and Treese nursing textbooks that I have, that I actually used when I was in nursing school. So the nursing diagnosis links the assessment phase to the rest of the nursing process. So this is a really big link in the whole flow of things. If you can't develop a nursing diagnosis, then you can't develop a plan, you can't develop your interventions, and you have no idea what you're evaluating your patient for. So you have all this data, but without explaining, without identifying a nursing diagnosis, it is meaningless. So you have the assessment that identifies activities identifying the nursing diagnosis, so then your diagnosis describes the client's present health status. And then you use that description to develop activities to focus on planning and implementing to meet the needs of this health status of the client. So here we have again this knowledge map that that's also part of the Wilkinson trees, and it's kind of a rather interesting knowledge map, kind of interesting format. It kind of looks like if you're looking from the head down along the spine of a dog. I mean, there's one side, there's the other side, there's the flank, then the tail's out there. But anyway, that's just me and my mind. But again, look at the different components that we have. So we have the nursing diagnosis, and it branches off into two different things. So we have diagnostic reasoning that's supporting your nursing diagnosis and standardized language. There are several different types of nursing diagnosis. We have an actual risk, possible syndrome, or wellness. We are going to focus on the actual diagnosis here in this segment. Later on throughout the course, we're going to be bringing in other different types of nursing diagnosis, the risk diagnosis, the possible diagnoses. The syndrome and wellness nursing diagnosis, it really don't need to get into that at the LPN level. That's more or less at the RN level, because now we're developing into different types of care plans. We're developing a collaborative care plan, other things like that, which we don't really need at the LPN level. But if you go on for your RN, then you're going to definitely dive into those types of nursing diagnoses as well. And then your nursing diagnosis as well consists of a problem, an etiology, and defining characteristics. We'll talk about that more later on. And then you can go into the diagnostic reasoning. Again, we did a whole presentation on critical thinking. That's where that comes into play. And then standardized language. So there's several different things out there. So you can use stuff that's already a part of the electronic health record that you can just kind of pull in. There's a whole volume of Neanda diagnosis, Neanda 1 diagnoses. There's a whole book of it actually you can buy if you really want to. And the advantages of this is that it supports computerized records, communicates nursing knowledge, it's very efficient, it's very standardized, facilitates research, and provides patient improvement initiatives because of that standardized language. But at the same time, though, we're labeling our patients. And also, it's not necessarily very patient-specific. They're very vague, and they're not very mutually exclusive. So those are some both pros and cons to using standardized language. That's nice, but I kind of don't like the setup of this, so we're going to reinvent the reinvention here of that flowchart to kind of help you give it a little bit more of a standard, how one step kind of moves to the next step kind of thing. So for our first thing, we have diagnostic reasoning. And this plays into our critical thinking podcast. If you have not listened to that one, stop here, go back and listen to the critical thinking podcast first before you continue on, because that's going to help you out a lot, not just with this presentation, but also with the implementation and evaluation presentations. But anyway, so our diagnostic reasoning, these include things like clustering cues. This is where you get into analyzing, interpreting data. Identifying the problem in something called an etiology. This is where we draw conclusions and inferences. We prioritize our problems. And we also identify types of nursing diagnoses. Once we've gone through this, then we can move to our second step, which is now we're talking about standardized language. This is how we're going to formulate and phrase our nursing diagnoses. So again, we kind of already talked about it. There are some pros and cons again. Here we are labeling. Our patient, which we don't like to we don't like to label our patient because it sometimes has a negative connotation to it. And again, pros, EHR. This is how you can communicate your knowledge, particularly your nursing knowledge. Those kind of things. So once we have that standardized language, now we can actually develop our full-blown nursing diagnosis. So we can have several different types. Again, we can have an actual, we can have a risk, which are the main two at the LPN level that you're going to be dealing with. Other things that you're going to have are possible or even potential. And that's a little bit different than a risk diagnosis. Sorry about that. But there's a slight nuance to it. Syndrome. Then also wellness diagnosis. And again, those last three you don't necessarily get into very much at the LPN level. We're going to be really focusing on the actual and the risk. And even in class and in this lecture, we're really going to be focusing more on the actual nursing diagnosis, on the actual problem. So this is a really nice flowchart. There's a couple of them here. There's one more after this. I really like it because what this does is this really allows you the opportunity to ask a statement or to ask a question to really determine whether or not you really need to write a nursing diagnosis for this, if you have enough information for a nursing diagnosis, and which is the most appropriate one format to use. So at the time of the assessment, does the patient have enough signs and symptoms, defining characteristics to actually identify a specific nursing diagnosis? Yes or no? You either have it or you don't. If you start going, well, maybe, no, you're thinking way too much in detail. Do you have enough information? Yes, no. Yes, now you can go to and figure out an actual nursing diagnosis. Then you need to determine etiology, and then you can develop your interventions. If the answer is no, then you need to go a little bit further. Are there risk factors present that will make it likely that a problem will develop if you do not intervene? Yes or no? Again, if you're no. Yes, there is a potential for a problem to develop. Say, for example, that we have a patient that's NPO. Is there a risk for nutritional imbalance? Yes or no? Is he only going to be NPO for 24 hours? Yes. Then is he going to be able to eat afterwards? Yes. Then is there really truly a risk? No. Is this patient NPO for 4 days because he's diverticulitis? Yes. Is there a risk for not meeting nutritional requirements? Yes. Now you have a risk nursing diagnosis, and now you can do interventions. But if your answer is no, then are there signs and symptoms or defining characteristics that include the possibility of an actual nursing diagnosis, but not enough for you to be certain? Yes or no. Again, this is all very black and white. People all the time try and make gray areas out of this, and there really isn't. There are no gray areas either. You either have the information, you have the data from your assessment, or no, you don't have it. And this is where you do your clustering. This is where your clustering comes in to be very beneficial. Either you have something in your cluster, or you don't. It's that simple. Don't make it any harder than it is. If you start going, I don't know, you're thinking too hard. You're thinking way too much into this. But again, once you get past here, you're kind of going into now RN territory, and we don't deal with a lot of this at the LPN level. We're focused on the actual nursing diagnosis, or maybe a risk or potential diagnosis. That's it. That's all the further at the LPN level we need to go. If your answer, once you get to, are the risk factors present that make it likely a problem will develop if you do not intervene, if you say no to that, then you can hand that off to the RN. That's like, okay, I don't need to worry about that. That's a little bit more advanced knowledge. The other thing, so we have nursing diagnosis. So this is where I'm getting, so go back to this slide again. So where I'm getting from this, okay, we can stop at the risk diagnosis at the LPN level. This is kind of where I'm getting at. So, okay, so does data analysis indicate a health problem? No. Then it's wellness, then don't worry about it. We don't need to go any farther. Wellness diagnosis, that's going to be an RN thing. But yes, if you can say, yes, this data analysis does indicate a health problem, now we can go a little bit further. Break it down into this, and I love this at this segment. Is this an actual problem? Yes or no? It's clearly defined. Is this an actual problem? Yes. Then we have a nursing diagnosis. Then we can go forward and make our nursing diagnosis. But is this an actual problem? No. Look at this. If you can say yes to this, medical diagnosis. Or no, is this a potential physiological complication? Then go further, answer no, then you need to go back and look at your data again. Maybe you're missing something, maybe you need to get more data to be able to make a better decision. If it's yes, then it's a collaborative problem. Again, this is something that you're going to be more concerned about at the RN level rather than the LPN level. Medical diagnosis, this is going to be all of your providers. This is going to be your PA, your nurse practitioner, or your physician, your MD or DO. So again, at the LPN level, don't forget about this question here. So we said, yes, there's enough data analysis to indicate a health problem. Can the nurse legally provide most of the interventions to prevent or treat the problem? Other words, is this in your scope of practice? If you need to recall, if you don't remember what scope of practice is, or if you don't know what the LPN scope of practice is, go back to week number 2 in your lecture, in your medical legal lecture, and go to the State Nurse Practice Act and look at the LPN section. If it is within your nursing practice, within your scope of practice, then yes, now you have a nursing diagnosis. If it is not, is it an actual problem? Yes, then it's a medical diagnosis. If no, then you really don't need to go any farther again, because that's going to be more for the RN. So again, we're really concerned about the nursing diagnosis, specifically the actual problem or the risk problem. So formulating the nursing diagnosis. So first of all, you need to, before you can even, again, go back, you need to go through those flowcharts. You need to analyze and interpret your data. And there's several things that we're looking for as we're analyzing and interpreting to kind of help you like giving you an idea of what you're looking for. So first of all, we need to identify significant data. What do we mean by significant data? What's the definition for that? Well, basically what that is, again, what we're talking about in assessment is it's a deviation from established norms or your patient baseline. So your patient may already be off the statistical norm already. However, they have their own set of normal values, and if they're away from their there's a deviation away from their own baseline. So say, for example, our patient is a COPD patient. They're normally on 2 liters of oxygen at nighttime. However, recently in the last couple of days, they've had to wear oxygen even during the daytime because they can't get enough. They have a hard time breathing. That is a deviation from the patient's baseline. They're already deviated from the established norms because they have to use oxygen at night. But now they're even farther away from that. They're away from their own normal, because now they're wearing oxygen 24 hours a day. So that ties into, so changes in usual health patterns are not explained from developmental or situational changes. So you got to take it with a grain of salt. What is the context again? So we're looking at what is the context of this deviation. Are there indicators of delayed growth and development? We just finished up all of the growth and development modules. So you should know what stage of development for what age bracket. Where should they be at? Are they within, or have they exceeded what's expected at that developmental stage? Are they lagging behind? If they're lagging behind, then there's cause for concern. Are there changes in usual behaviors and roles or relationships? I'm going to add as well, or patient baseline, particularly if you're dealing with someone with mental health issues, dementia, Alzheimer's, autism, or non-productive or dysfunctional behavior. A lot of times we think about that. Activities of daily living. Also, at this point in time, and also to allow us to interpret and to analyze our data, we need to start clustering our cues. Once we cluster, this is going to help us identify data gaps or inconsistencies. So say for example, we have subjective complaint of X, but then our objective data contradicts or does not support the subjective claim. So say for example, let's use pain. Our patient says, oh yeah, my pain is 10 out of 10. However, their vital signs have not changed. They're neither increased or decreased. Some people have a vagal response and their vital signs decrease. So their vital signs are within normal limits. They're a baseline. There's no visible signs of acute distress. There's no sweating. There's no palpitations. There's no grimacing or facial expression. So we need to question, are they really having 10 out of 10 pain? They're sitting there playing on their phone. They're playing Minecraft. Just kind of grunting, barely acknowledging what's going on. Are they really in 10 out of 10 pain? Think about it. You need to explore a little bit more. Delve a little bit deeper about what is going on. And then from all of that, you need to draw conclusions. So once you've clustered, so we say, here are my problem areas, here are my the items out of my assessment, out of my data that are similar to each other, that go with one particular cluster. They are consistent with subjective complaints, and this is what I'm going to go with. So when you need to go down, you need to actually verify with your patient. Is this accurate to what I'm interpreting is what's going on? Would you agree with me or disagree? What if your patient disagrees? Then you need to make a decision as to, did you miss something in your assessment? Do you need to go back and reevaluate one section? Or B, is your patient just saying it to say it, that they're asking for something, they're trying to direct you to a specific treatment or modality that maybe they want because of the effects or because they think that it's going to help them, but in effect it's really not true at all. So you need to make that decision as an independent practitioner. Don't leave it up to the RN or to the physician, because everybody relies on each other for what they interpret is what's going on. A lot of times at the physicians, they appreciate and they expect the nursing staff at any level to point out, hey, there's some inconsistency here with what I'm being told and what I'm evaluating, what I am observing from this patient. So we need to take another look at this. This is where it comes into play, that you are the eyes and ears for the provider and for that care team for that patient. So once we've verified that, we've come up with our clusters, we've figured out everything that we've figured out our groupings, we've prioritized our problems. Now we need to write that diagnostic statement. So go back to the very first slide here, where that link between the assessment and the plan and the implementation happens. This diagnostic statement is what links everything together. This is what takes that data and molds it into something that we can actually work with. And it combines several different segments. So we have the problem, which is the health status or human response to a health problem, the etiology, which we'll talk about a little bit more, and then the symptoms. So this is data that relates to both the etiology and the problem. Every one of these segments must support the previous one. So the generic format for our diagnostic statement is going to be a problem related to our etiology, as evidenced by, you can also use the abbreviation AEB, the signs and symptoms that you have from your assessment. So again, this all comes from your data from your assessment that you have completed. So my assessment is going to support my etiology, which is going to support the problem that I have chosen. So you need it needs to make sense, not just going from problem to etiology to your signs and symptoms, but it needs to make sense in reverse. My signs and symptoms relate to my etiology, which then also relates to my problem. So you need to read them both. At the very end, you need to read it both forwards and backwards. So let's look at etiology a little bit more, because this is an area where people really trip up quite a bit. This is probably the most confusing part of the entire diagnostic statement. So, and I put quotes here because this is a direct pull from the book, from Wilkinson and Treese. I liked it, so I kept it. So in etiology are factors that are causing or contributing to the problem. And these can be pretty much anything. They can be related to pathophysiology. They can be related to treatment. They can be situational, social, spiritual, environmental, what have you. If they relate to that problem, they can be a part of the etiology. What is contributing to that problem? So once we identify the etiology, this is going to dictate and identify the type of intervention that we are going to use to trying to reverse the etiology, or to reverse those factors that are contributing, or to try and deviate or lessen the impact of the contributing factors to the problem. If you are unable to determine the etiology, first of all, you need to go back and gather more data. You don't have enough data at hand, because again, you're going to need that data to really develop a specific intervention for your patient. There are select circumstances where it is acceptable to put in your diagnostic statement etiology undetermined. But those are few and far between, and especially at this level, you must always, 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 always identify an etiology. Always. And here as well, you need to think about it in terms of scope of practice. You cannot use a medical diagnosis as your etiology, because medical diagnosis, that's out of our scope of practice. So let me give you an example here. I'll give you the basic format again. So writing a nursing diagnosis. So there are several different types. So we're going to talk about something called, I'll give you an example of something called a basic 3-part diagnosis. Can't do it. So, and then what I'm going to do here. So this is the format that you're going to want to follow when you're writing these diagnoses. So first of all, you have your problem. Again, this is going to revolve around patient health status. Or response. That needs changed. So then this is you're going to connect. This is where your related to comes in. Then you have your etiology. Factors, again, that contribute. To create a risk. Which may include several factors. Again, it cannot contain a medical diagnosis or treatment. And then you have your next connecting statement, as evidenced by, or AEB. And this is your signs and symptoms that support what's going on that's influencing it and what clues you off to this problem. So this all comes out of your physical assessment and your social assessment of the patient. So these are all in support of your etiology and problem. This tells you, this is your rationale for what's indicating to you that that a problem actually exists. So a lot of times, like for example, vital signs go in here, other assessment data goes in here as well. So what do you observe? Are there like cuts in the skin? Or is it, again, you kind of write your observations in. So redness, swelling, purulent discharge to a wound might be signs and symptoms. If you're doing infection related to cut on arm, and then you have redness, swelling, tenderness, pain, fever of 101.2 Fahrenheit, that kind of thing. So that all goes in your signs and symptoms. But this format is what you're going to use routinely for any type of three-part diagnosis that you're going to write. And again, you have to have all three of these segments to have an actual three-part diagnosis, and this is going to be your expectation to write three-part diagnosis. So you problem related to an etiology as evidenced by your signs and symptoms. What is telling you that, what is telling you that there is a problem? What are you using to support your other two segments? So then, which problem first? You've developed several problems. Which one do you go for first? Use your priority setting frameworks that we've talked about. Maslow's hierarchy of needs, your ATI priority setting frameworks, those type of things. Those will help guide you of which things that you need to address when. And this is where you bring all of your knowledge, both practical and theoretical, together to sort through all of this data. It's overwhelming because you've got an immense amount of data that you've collected through your assessment. You've got a more immense amount of data now that you have started to compile your nursing diagnoses. So now what do? This is where you still need you need to incorporate your critical thinking. And again, we kind of spelled that out for you in the critical thinking presentation. Again, if you have not watched that, go back and watch it. And if you don't remember exactly what part I'm talking about, go back and watch it again, because this is going to tie into every single segment of the nursing process, of the ADPI system. Things that you can use kind of as a guideline to look at and to remember, to kind of like analyze your diagnostic statements to see if it's something called a quality diagnostic statement. So first of all, do not rely on, if you're using a NANDA diagnosis, don't rely on the label only. These need to be individualized to your patient. So you may need to, and you actually not may, but you will need to kind of, I don't want to say fudge things a little bit, but you're going to need to change things, you're going to need to work things a little bit to make it specific to your patient. Problem in etiology makes sense regardless of direction. what I mean by that, so you're reading, say for example, so you have your problem, then you go to your etiology, and it makes sense. So what I'm talking about there, so what you need to do then is you actually need to go the opposite direction. So we have our problem. So now you need to read your etiology and then your problem. And there's one of two choices. Either A, it makes sense, or B, let me actually put a different color here, or B, it does not make sense. And in that case, you need to go back, review, and revamp until it does make sense, going from etiology to problem. Again, avoid using medical diagnoses and treatments as etiological factors. Again, it's something we cannot treat, or we cannot write a nursing diagnosis to change a medical diagnosis, because that's out of our scope of practice, because medical diagnosis is based on lab data, is based on advanced assessment, and what the treatments, medical treatments focus on are prescriptions, or focused on other therapies that require an order by an advanced provider or a physician. You need to be able to write your statement clearly, write your statement concisely. Make sure that your statement is descriptive and specific, and state the problem as a patient response. Again, remember, we are looking at how our patient is basically unable to adapt to some problem that is going on. Use non-judgmental language, and then avoid legally questionable language. Welcome to the gray area, and welcome to the world where every single thing is going to be reviewed by every single person. And something that I brought up again in week, going back to week 2, and some things that I've talked about in the documentation lecture is, it's not anymore a question of if you're going to be going to court, it's a question of when. That's how you need to practice, that's how you need to document, that's how you need to basically work as a professional. Expect that. So you need to cover yourselves as best as you can. So you need to pay attention to how you are wording things, because sometimes if you're not clear, if you're not concise, if you're too vague, they can be interpreted in different ways, and they can be interpreted in meanings that are outside of your scope of practice and are in legal gray areas. And that will come back to bite you. So again, make sure that they are descriptive and specific, that they're clear, they're non-judgmental, and that you're using a language that is appropriate for your level and scope of practice. With that, this is going to end this podcast. Go back and review the previous 2 podcasts if you have any other questions. If not, look forward to your comments and your reflections on this. And the implementation podcast is next. Thank you very much.